Okay, we might make a start, everyone. Welcome to session 4.7 on the launch of the updated Colonoscopy Clinical Care Standard and Healthcare Variation Report. I'm Denise O'Connor, Professor of Research in the School of Public Health and Preventive Medicine at Monash University and co-chair of this session with Gregor Brown. Gregor, would you like to introduce yourself?
TBC, I think.
Oh.
But here I am. I'm a gastroenterologist in Melbourne, and I've been involved with the recent upgrade of the Colonoscopy Clinical Care Standard, among other things.
Great, thanks Gregor. And we'd like to begin by acknowledging the Wurundjeri people of the Kulin Nation, traditional owners on whose land we're meeting today, and pay our respects to their elders past and present, and also to First Nations Australians attending today. Now this session's going to be divided into three parts. First, we're going to hear from Conjoint Professor Anne Duggan on the updated Colonoscopy Clinical Care Standard, which is being launched today. And then second, we're going to have a panel discussion with national experts in colonoscopy care. And then finally, we're going to have two free paper presentations related to colonoscopy. And we're going to hold over all questions for the speakers until the end of the presentations. So now I'd like to introduce Professor Anne Duggan. She's the Chief Executive Officer of the Australian Commission on Safety and Quality in Healthcare. She's an academic at the University of Newcastle, a gastroenterologist and a well-known champion of high-quality colonoscopy. And she's going to present on renewing the national approach to quality in colonoscopy, the updated Colonoscopy Clinical Care Standard and Healthcare Variation findings. Thanks, Anne.
And thanks, Denise. And I too, on behalf of the Commission, would like to acknowledge the traditional custodians on the land on which we're presenting and on the land on which we work. And the Commission certainly is committed to partnering with and learning from Aboriginal and Torres Strait Islander peoples through the work we do. So the Commission works in partnership with clinicians, consumers, patients, policymakers and healthcare organisations to try to achieve a sustainable, safe and high-quality health system for all Australians. Our purpose, as set out in legislation, is to lead improvements in the safety and quality of healthcare so that all Australians receive better care everywhere. So today I'm going to highlight two areas in which the Commission has been working for over 10 years to try and improve the quality of colonoscopy in Australia. We develop clinical care standards which set the standard for the care that Australians should expect to receive, and we have been presenting atlas data, looking at the data by where people live to see what is going on across the country and see where there might be unwarranted variation and the need to apply best practice. Sorry about that, gone the wrong way. So today I want to launch the revised Colonoscopy Clinical Care Standard and the Atlas Focus Report. The revised Colonoscopy Clinical Care Standard has been strengthened and updated. We achieved major gains early on with the standard by adopting some of the great work that the GE Society started, and I'll talk about that in a minute. And we, 10 years ago, provided important data on the variation in colonoscopy that was occurring across the country. And this focus report I'll talk about today is looking at MBS data by where people live overall and where we are seeing repeat colonoscopies at less than 3 years. And we've chosen 2 years and 10 months to ensure that we're not just picking up people who might be due for a 3-year colonoscopy. So how do we do improvement in colonoscopy? So Australia's been in a unique approach, has had a unique approach to colonoscopy. We have a national bowel cancer screening program, and we developed a model which was based on the Colonoscopy Clinical Care Standard, which adopted what was a voluntary certification and recertification program, and then put it together and then mandated it so that every hospital across Australia, be it a day surgery or an acute sector hospital, must be accredited to that standard. So we've embedded the standard across the system. And so hospitals need to demonstrate that they are complying with that standard. And I want to give you an example just of somewhere where a facility that didn't meet the standard suddenly realised it had work to do, and the benefits of actually embedding the standard in accreditation. So it's a short video.
When we received the not met for the Colonoscopy Clinical Care Standard, I think a few different emotions came across the team. So one, we always look at the feedback from the assessors as positives and opportunities for us to grow. Second aspect, with this particular clinical care standard and the work that we needed to do, it wasn't a quick fix. That was when our work really started to focus on looking at how we can measure the variation in practice for the colonoscopy clinical care standard, and then how we can bring that into a standardised reporting and governance structure. One of the major wins we had in that element of the probation endoscopic software was we were able to make the fields in the probation software mandatory for the proceduralist to data entry into, so we could capture that data for every colonoscopy that was performed across the districts. Not only was it about gathering the data and conducting the audit, it was about the review process and making that review process meaningful, and also giving the review an opportunity to escalate any areas needing improvement. So that was one of the major elements of the project, was standardising the governance structure from the site level all the way through to the board of the Northern New South Wales Local Health District. I think clinicians on the floor, sometimes I think the governance and the governance structure is probably the last thing on their mind, and rightly so. They're busy clinicians looking after patients, but I think bringing to light for them to understand that not only do we need the audits conducted, but we need that review process and we need the governance structure in there to really make sure we're meeting the requirements. That really actually comes down to, in the end, providing better patient care for all those that come and have a colonoscopy with the Northern New South Wales Local Health Districts.
If you'd like to see the full video, you can follow it on our website or QR code. The landscape of colonoscopy in Australia has changed over the last decade. Bowel cancer incidence deaths are decreasing from 35 per 100,000 in 2000 to 19 per 100,000 in 2024. But we do have an ageing population, and we do need to ensure that we continue to drive down bowel cancer, given that we have one of the highest rates of bowel cancer in Australia. What the Atlas Focus report is telling us, that if you look at MBS subsidised colonoscopies over a 10-year period and map the data according to where people live, not where they receive their colonoscopy, then you're seeing marked variation, suggesting that we really have work to do in getting that standard embedded. And if you focus on that subgroup of people who are having colonoscopies at less than 3 years, and we pick 2 years and 10 months, we are seeing marked variation that really does need to be explained. The Focus report shows an overall decline of 8%, but that decline is predominantly in remote areas, more than major cities, and there's in fact a rise at the highest SES groups and a decline among the most disadvantaged. And the variation, as you can see, we've colour-coded it, and because it's age and sex standardised, it's valid to compare regions. There is a marked variation, suggesting that we have an urgent need for this updated standard. So I want to turn to you and talk about the updates in the standards. As I said, we have now embedded accreditation of colonoscopists. Over 2,200 colonoscopists are accredited across Australia. So if you have a colonoscopy, you're having a colonoscopy with somebody who is very well trained. One of the areas where we know work needed to be done and where we're focused is on communication and information sharing, ensuring that patients are being referred up with the information they need for the clinician to make an informed decision about the need for colonoscopy, and ensuring that the information goes back in a timely fashion to the patient, to the GP, and to whoever else needs to know, so that people don't get lost to follow-up and procedures aren't repeated unnecessarily. We've emphasised again, now that we have high-quality colonoscopy, the importance of the surveillance guidelines. We've updated the ANSCA guidelines for sedation, and we have also included areas for cultural safety, because we know that Aboriginal and Torres Strait Islander peoples have the highest rate of bowel cancer in this country, and many of the reasons for non-attendance stem from a lack of cultural safety in our facilities, and so we've given guidance to ensure that that is not a problem that causes people not to attend when they need to. So, in summary, we now have a standard that says what good looks like and what we should have across the country. And we have data to start people thinking about, well, why is it so that we don't have consistency across the country? We're calling for action to ensure that colonoscopy is used appropriately and repeated when recommended, to prevent some people receiving unnecessary procedures while others miss out or have their procedure delayed because of waiting lists. So there is something for all of us to do, whether we are clinicians, policy makers, health service managers, consumers, patients, or societies such as the GE Society or the colleges more generally. So on that note, I will end. I refer you to our QR code, where we're very happy to hear from you. We have lots of resources, and we really, really want to bed this down for all Australians. Thank you.